Good afternoon. I think probably we are all sleeping right now, but still, I think I have a few points to make. Actually, I'm learning today. And honestly speaking, that I'm going to talk about that some of our volunteers that who physically had been there in Bangladesh, they taught us a lot. And the part of the discussion that I would probably had, they already told you. And I found that it's an enormous experience for them because actually that is creating our future generation leaders. They're understanding what's going on in the real world, and they're taking that experience and they're going to spread that experience to others. That's enormous satisfaction for us. And the working for this type of organization is a gratification yourself. As I know as a physician that when you do something good, that you feel the feeling of love. And the neuromediator that you release in your brain, when you give a givings, when you donate something, you get the similar release of the neuromediators in the brain. So it's kind of addiction. When you really love to give, then it becomes an addiction. So I hope that you'll get the feeling of that when you leave this house. We have this poverty level right now about 31.5% by statistics from World Bank from 2010. But whatever you do, we understand one thing, that in any country, the healthcare, they have different tiered services. One is government policy, government healthcare service, private healthcare service, and in third world countries, mainly a lot of domination by the NGOs, like DCI. The reason I'm talking about why DCI got into that, as Ehsan talked about that, when he thought about that, probably he'll do the child rights and blindness program. When he started that program, we found out that there are a lot of other problems, they're integrated part of that. You cannot solve that problem until you make sure that you take the whole picture in your mind. So that's why the healthcare part came to DCI. And we understand that some of the international organizations, when they're like USAID or I think World Bank and other, they're trying to help us, definitely. But sometimes we see some discrepancy how the realistic help we can get in these poor countries, because their standard recipes sometimes do not work. The reason being, we need to understand the need for these people particularly. As for example, if you're working for the poorest people, what their needs are, they don't need the standard package of healthcare delivery, because they're not going to benefit with that. So, and you need to learn from them what the need from them, so that we can tailor our services and direct our services to them, that we can get the best ROI, we call return of investment, with a simple intervention. As just we saw a presentation right now that like mosquito nets, treated mosquito nets, how a small intervention it makes a big difference. So, and I'm talking about one project that we're thinking about, that in adolescents, like from 10 to 18, childbearing age, two simple intervention, like their treatment of anemia, just iron tablets, and treatment for like germs. I'm talking about parasites like helminthiasis. If you do these two treatments, you can make a huge difference in their prenatal care. So simple intervention sometimes makes a big difference. And we need to understand what's the spectrum of diseases in these countries, and our poor resource, budget allocation, and basically lack of knowledge, and particularly in this poorest section of people. And when you look at that, our majority of the healthcare services is definitely by the government. And I have to say that there is an article in 2013 in Lancet, just 8 series article, and there's a paradox between that, because the reason is we have very poor resources. At the same time, also we have a lot of like corruption, less accountability, and poor governance. How we made a big difference in the reduction in mortality, reduction in the infant mortality and maternal mortality. So that's a very nice article. If you have time to look at that, the Lancet article 2013, and it's huge. It is in collaboration with World Bank, World Health Organization, and different research organizations from Bangladesh. But I think that a part of this, the NGO, why NGO comes into play, because there's a big gap because, in the private healthcare, you cannot just pay and go there. Poor people cannot pay. And though they have like few beds for poor people, but they're just for the namesake. Because actually they're being used by their acquaintance or some other people, they don't get the benefit of that. But definitely government is doing a big part of that, but because of this accountability and the corruption and lack of coherence of the policies, everything, so we had some serious problems. That's the NGO came into play. So DCI definitely has a big presence in the healthcare sector. I'm talking about in the Kallanpur slum, we serve over 9,000 population, and we focus on the need of the poorest people. We wanted to make sure that we let them understand that, educate them, there's a basic healthcare available. And also, we focus on that they have the access to the information, and also we facilitate the access. And that you saw on several presentations previously, that how we do it. The educational, hygienic education, nutritional education, we have social worker going door to door, because a lot of women will not come out and seek help. So you have to go, you have to direct this healthcare to the houses. That we can make a difference in those population. So when I visited last time the Kallanpur slum, and I'd like to give a lot of credit to our some of the physicians sitting here. They have a big involvement in this Kallanpur slum health clinic we call HUP, Healthcare for the Unprivileged. And I thanks for their contribution. When I visited there, and when I saw that what we could do from the US, and actually being an Emory physician, and I was involved in some telemedicine in Emory, I thought that I could probably do some contribution through telemedicine from here back to the country, to this poorest section. That's the idea came through. Initially, we started through the Skype, and we decided to do that. We'll do one-day clinic, 1 hour. We sit down about 11 o'clock night. That is 9 o'clock down there for the timing. In winter, we get it at 10 o'clock here. But we sit down 1 hour a day. And we have been doing it 1 hour a week, sorry. We have been doing it about 1.5 years. And we have seen, and these patients we are seeing is consultative. We are doing some consultation. That there are 2 doctors there in the clinic, and they see those patients, they think that they need more higher level of consultations that poor people cannot afford. So we thought that we have some network of physicians here in the US from Bangladeshi origin, so we can gather them and have some coordinated care, so we can directly offer them the consultative care. So we started through Skype, and then I have some mind in technology myself, so some of our friends, we thought that what further level we could go forward. So we decided to create a cloud-based electronic health record system. And it's actually very robust, and I work in Emory, and it's a Cerner Millennium, we use that. So we have the full-fledged electronic health record system we developed in the Salesforce.com platform. And the idea behind was totally philanthropic, that we're going to give away this electronic health record system. Anybody wants to use it around the world, provided that they're serving the free clinic. Okay, so we have been using that, and it has a video conferencing capabilities. We have been using that. And also we have built-in consultative pool of doctors. If they request a consultation, they automatically fits in who is the physician available here to consult that particular purpose. So then with the available time, they sit down with the video conferencing, they do local consultation. So what we can do for the, this is a clinic, and it has some cost, involvement, and we're relying on that, on the donation-based, but we have a budget, and we have to fulfill that budget. We have to have a yearly budget to carry out our work for the next year. So we're thinking about this direction right now, that we might have to really do a big drive, individual level and corporate level, to get an endowment that have enough sufficient fund to give a stream revenue to run the clinic. And also, we recommend that we can do a local network of physicians in Bangladesh, that everybody has some friends in medical school or somewhere. They can do a network, local network, because I talked to some of my friends that, yes, they can see 1 or 2 patients per week, no problem, and they will see it free. So we're developing that network, and we're coordinating through the whole thing with the electronic system, software system. And also, we are coordinating here the specialist network system in US from the doctors from Bangladeshi origin. Actually, 12 Emory doctors are involved in this network. 12 Emory cardiologists involved in this network. So we're creating this network of doctors here, connecting them so that we can do very highly specialized consultative care. So and also we can do a network of pharmaceutical companies locally in Bangladesh so that they can do some free medicines for them. So we understand that, the new change in, the unprecedented way that the population growth and density of the population in the slum areas is growing. And the new climate changes, new environmental changes, and the occupational and health changes, hazards, we're seeing the new dynamics of the new problems in the healthcare, and particularly even we see in these populations. So we have to strategize, we have to make some new strategies how we really need to help those people. So you have to keep in mind to keep these challenges in front of us. Thank you very much.